Good afternoon, everyone. This is Gail Donovan from the Scottsdale Institute, and welcome to this afternoon's webinar, Supporting PCPs as They Shoulder the Burden of Mental Health Care. Just as a couple of brief housekeeping type reminders, we do record our sessions, and so you have been placed off camera and muted. Our recordings will be posted along with today's slides on our webinar. Usually they'll be up by no later than tomorrow morning, and you'll have access to them. We also will ask you for really a quick participation in a survey at the end of our webinar today. It helps us to receive feedback as we plan future content for our webinars and other events going forward. So I'd like to introduce our speakers this afternoon. We're delighted to have Dr. Ann Travis, who is the Director of Clinical Content of Advanced Clinical Decision Support for UpToDate, and Julie Frey is Head of Product for Healthcare Providers from Wolters Kluwer Health, which is one of our sponsoring organizations. As we all know and have heard a lot about, especially post-COVID, mental health is a crucial component for overall well-being. And primary care physicians play a vital and increasing role in guiding patients toward the help they need. However, providing effective care can be incredibly challenging, especially without specialized training. There are, fortunately, organizational support tools for health system leaders to invest in that are essential for facilitating mental health care and primary care. What we're going to learn more about today is how a committed investment, particularly in clinical decision support tools, can increase efficiency of the practice environment, the communication strategy, insights for integrating mental health services, and frankly, also the outcomes experienced by the patients cared for. So without further ado, I'm going to turn our discussion over to Julie. I want to thank everyone for being with us here today, and especially our presenters. Julie, take it away.
Gail, thanks so much. Good morning, good afternoon, everybody, depending on what time zone you're in. I'm Julie. As Gail mentioned, I head up product for our provider market. So, just to maybe make that more real for folks that work in healthcare, those products include UpToDate, Lexicomp, Emmy, and Medispan. Lots and lots of products looking at clinical decision support, patient engagement, and drug decision support. So why don't we get stuck into some of the material? So, mental health is really a hot topic at the moment, largely because it affects a large proportion of our population. And what we've seen under COVID is really that proportion has increased. More than 23% of adults in the US live with mental health challenges and illness, and only 28% of the population lives in an area with enough mental health professional support in order to get the care that they need. And if you can move us forward. And because of that pressure and the limited supply of professionals, the role of the PCP with regards to mental health is really has really evolved. And what we're seeing is up to 40% of patients seen by a PCP or an APP report a mental health concern. So a lot of that pressure and that need and that demand for support and services is really moving to the PCPs. And as a result, they're becoming kind of the front line of mental health. So despite not having specialized training and in many cases having limited support, they're delivering an astounding 60% of mental health care, and they write 79, so almost 80% of prescriptions for antidepressants. So really the majority of antidepressant prescriptions are coming from our PCPs. And that's a huge evolution compared to a decade ago. And now what I want is to kind of juxtapose that in context with the little time that PCPs really have with patients. So if we think about this webinar, PCPs typically only have 15 minutes with patients. And so during this webinar, That's the equivalent of PCP seeing 4 patients and needing to perform all the duties that you see listed on the screen. A PCP is trying to go through all those actions and still to provide the best possible care to their patients. And as PCPs are becoming more and more engaged in managing mental health, we need to make sure that they have the right tools to support what is a very, very challenging task of managing so many needs in such a short period of time. When we speak to our users of our products and we speak to clinicians, they really feel overwhelmed and overburdened. And they feel that pressure and they feel the need from their patients to help them. Those patients really feel like they have nowhere else to go. PCPs are turning to a number of tools to help provide support and guidance and to streamline some of the care that's being provided. But there's a lot more that we believe we can do and we should do as we support them in this challenging task. Why mental health, part of why I think mental health has had such an outside focus, if you look outsized focus, if you look at media attention and you just look at just generally the spotlight on mental health in the last few years, it's not just the sheer volume of patients with mental health illness and other conditions. It's also a lot of those patients have another condition. So, you know, the stat is incredible to me. 51% of people with mental health disorders also have a chronic medical condition. Those that can include high blood pressure, coronary heart disease, heart failure, kidney disease, diabetes. Those chronic conditions affect over 48 million Americans, so huge volume of patients there. And the incidence of depression in conjunction with some of these chronic conditions does vary, but we can see it to be incredibly high. The number of patients that both have depression and Parkinson's, for example, is 50%. So just some astounding numbers of folks with comorbidities and other health challenges they're trying to navigate at the same time as trying to manage mental health. You know, the cost, as you start to think of the administrator and you think about organizations, so moving away from the impact on the patient and the impact on the PCPs is primary care patients with major depression have 50 to 100% greater medical costs than non-depressed patients after controlling for a number of factors. So the cost to manage these patients is significantly greater. And so the burden on healthcare is really being felt. In addition, just kind of another compelling stat just around the burden to the system, patients with severe mental health illness are over 4% higher at risk for 30-day hospital readmission. So just generally, you're seeing sicker patients costing systems more, and the readmission rate being higher for this population. Lots and lots of reasons to really think about what else we can do to support patients and PCPs in tackling mental health. Maybe what I'll leave you with as we think about the challenge and we think about the magnitude of the challenge. We have spoken to many healthcare leaders, and they're and understandably so. Leaders are looking to try to hire more specialists. They're looking to encourage their PCPs to refer as much as possible in an attempt to kind of close some of that demand-supply gap and reduce some of the burden on PCPs. And that is absolutely the right thing to do and the right place to start. But the reality is we're never going to fully be able to close that demand-supply gap. PCPs are going to feel that pain, even in organizations where they've got where they've really focused on hiring more specialists. When we speak to our PCPs, they remain feeling overwhelmed and overburdened. And kind of where that lands for us is we need to think about navigating this new normal. We're not going to be able to take the burden off the PCPs. We need to find ways to better support and equip them in dealing with what is going to be an ongoing challenge. So I'm going to hand it over now to Dr. Anne Travis to really talk about some of the ways that we've seen success in terms of managing this challenge.
Thanks, Julie. So now that Julie sort of framed the problem, I want to talk a little bit about what we can do to improve mental health care delivery in primary care. And when we talk about improving mental health care delivery, I think there's a few things that are sort of my goals. So one is we want to provide PCPs with tools that are really effective for helping with mental health care delivery. But beyond that, we also want to look to see if we can do things to help increase efficiency as well as increasing satisfaction among the primary care physicians. So to start, I think we should think about what are some of the barriers to supporting mental health care within the primary care setting. And I think of this in sort of three buckets. So I think of systemic factors, clinician factors, and patient factors. So as Julie already noted, one of the big problems we have is that there are just too few mental health providers to help the more than 1 in 5 patients who have mental health concerns. So those patients are overflowing into primary care where lack of time becomes a really big problem. So as she said, a primary care clinician typically has about 15 minutes for a visit. And when you're dealing with things like mental health concerns, these are really deep personal conversations. And so they take more time than it might take to say, for example, ask someone how they're doing with their antidepressant. And so they really eat up a disproportionate amount of a visit time. In terms of clinician factors, a lot of this I think starts with training. So particularly among primary care physicians, a lot of their training is in internal medicine. So they may have some training in psychiatry, but it's really pretty minimal. And I think when you combine this with the fact that mental health disorders often feel like somewhat subjective diagnoses because there isn't a test, there isn't a blood test, there isn't an x-ray that you can do to make the diagnosis. This often leads clinicians feeling a little bit unconfident in terms of what they're doing. So they may not feel confident about the diagnosis, or they may not feel particularly confident about their treatment plan. This in turn then leads them to want to refer those patients to mental health care specialists, which again brings us back to the problem of there not being enough providers. Also, because primary care clinicians are really grounded in internal medicine, they tend to focus on medical problems during a visit, that you tend to gravitate to the things that you're more comfortable with. And so if you have a patient coming in who has anxiety, diabetes, and hypertension, there's a good chance that you're going to spend much of the visit time talking about their diabetes and blood pressure control, but you may not really spend much time on their mental health. And then we have the patient factors. One big one is that there's a lot of stigma around mental health. And what this means is that patients often are very hesitant to bring these concerns to their clinicians. So they may suffer with these problems for quite a while, which can then lead to them being even worse when they finally do talk about it with their clinicians. The stigma also has an effect on the visit itself because patients are often resistant to receiving a mental health care diagnosis, which means as a clinician, you have to spend more time talking to them to help them understand and to start the process of destigmatizing their problems. And then finally, as with every area of medicine, patients often have an incomplete understanding of their disorders, and this may be because of inadequate patient education materials. For example, if it's not written in a language that the patient reads, it may not be particularly accessible to them. Or materials may not have sort of the patient's cultural background in mind, so they may not feel particularly relevant to the patient. So all of these things come together on the patient side to really hinder adherence to their treatment plan, which then also blocks their ability to get better. So let's talk about some of the approaches to improve mental health care delivery. And I'm going to touch on 4 sort of major categories. So one of the options, as Julie mentioned, is adding clinicians. We can also think about alternative care models for delivering mental health care. Then implementing clinical decision support systems to support clinicians and patient engagement solutions to help support our patients. So in some ways, the simplest thing to say is we should just add clinicians. And a lot of systems are trying to do this. But I think we all know that there's a real problem of there just not being enough. And increasing the supply of mental health clinicians isn't a near-term solution. And I'm not just talking about adding psychiatrists. really for all level of care, from social workers to therapists to psychiatrists with subspecialized training in things like addiction medicine. There's a great deal of training required, and typically it takes 8 to 16 years to train a new provider. So if we're not able to quickly ramp up the number of clinicians, is there anything else that we can do? And one of the things is increasing the number of clinicians who are helping provide some of that mental health care. And here what I'm talking about is really helping people to practice at the top of their license and to off-burden primary care clinicians somewhat so they can really focus on the treatment piece. So I think a good example of this is in patients with depression, we frequently use something called a PHQ-9 questionnaire to assess how severe the depression is doing. And we use that to track their progress over time. So it takes a while. There's several questions that you have to go through where the patient reports how they've been doing in several different domains over the last couple of weeks. If you're doing this as a PCP during a visit, you might end up eating 3 to 5 minutes of your 15 minutes, which doesn't leave nearly as much time to deal with all of the issues. But if you ask your medical assistant as they're rooming the patient, if the patient has depression, to go over that PHQ-9 questionnaire with them, you've now saved the clinician several minutes during that visit that they can now devote to caring for the patient. In addition, you can make use of staff after the visit. So you could, for example, have social workers contact patients to find out how they're doing between visits and to problem solve around things like, are they having problems with their medications? You can also then identify patients who maybe need some escalation where their primary care physician needs to step in and make some adjustments to their treatment plan. And finally, we can engage the patients themselves. So for patients who are comfortable using something like a patient portal, you could give them that questionnaire ahead of time for them to fill out. That then gives them the sort of time to think about their answers, that they're not rushed through it. And I think a lot of people know sometimes it's easier to give a true answer on a form a little bit more easily than it is when talking to a person, particularly again, when you're talking about some pretty personal things, like asking, have you had thoughts about harming yourself over the last couple of weeks? So another way to expand our capacity for mental health care within primary care setting is looking at some alternative models. And a lot of you may be familiar with things like co-localization models. And the idea there is that you have people of different specialties working out of the same physical space. So you have psychiatrists and primary care clinicians working together. This is something a little bit different. So the idea here is that you actually develop patient-centered care teams around mental health. These are collaborative teams, and they work around shared care plans that incorporate the patient goals. It's a population-based approach, so your patients are tracked in a registry. That way you don't lose track of people. And key here is a behavioral healthcare manager who really is responsible for the patients in the registry. And they go through and they prioritize patients to ensure that resources are really going to the people who most need it. We then use measurement-based treatment to target. So the patient's treatment plans need to articulate clear goals, and then there's routine measurement using evidence-based tools throughout their treatment. And adjustments are made to the plans if needed. I think it goes without saying that all of the care provided really does need to be evidence-based. And then these systems also are accountable in that providers are reimbursed for the quality of care that they provide and for their patient outcomes. So there are 4 key members to a collaborative care team. At the center is the patient, and they're the one who starts by letting their primary care physician know how they're feeling. The primary care clinician then, if they suspect the patient has a mental health disorder that needs some help, can refer to the behavioral health care manager. And this is typically a nurse practitioner or a licensed social worker or someone else who has mental health care training. And they do an initial evaluation with the patient and they come up with a provisional diagnosis. That healthcare manager then works directly with the psychiatric consultant, who often is a psychiatrist, but it may also be a therapist, to devise a plan that's specific to that patient and takes into account that patient's care goals. The healthcare manager then reports that back to the primary care clinician who starts to implement the plan. But as part of that, the healthcare manager provides additional ongoing support by following up with the patient to do longitudinal monitoring, provide support such as brief psychotherapy or psychosocial interventions, and also serves as a conduit for communication among the clinician, the patient, and the consultant. So again, everyone's kept abreast of what's going on with the patient. Patients who are particularly high risk are prioritized, and we've come up with treatment plan modifications as needed to ensure the patients really are getting what they need. And what you can see is in the prior screen, I showed you this as sort of a 4-person care team, but this really scales much more beyond that. And the idea here is that you can really extend the reach of your mental health care professionals. So in a traditional model, your psychiatrist, for example, works one-on-one with their patients, which really limits the number of patients that psychiatrist is able to support. By bringing in the behavioral health care manager, we're able to extend that care to a lot more patients. Now, in this case, much of the psychiatrist's interaction with them is more indirect. It's through the behavioral health care manager. But if needed, they can provide direct care for those high need patients. Now, this is a bit of a shift for mental health care providers who are often very used to working with patients one-on-one. And so it requires a bit of adjustment to get them used to working in this slightly more indirect role. But there have been more than 80 randomized trials that show that this type of model is very beneficial. It's been associated with improved mental and physical outcomes for patients. It's also been shown to decrease the use of emergency services and hospitalizations. Now, this is not necessarily an inexpensive thing to implement. It was estimated by ICER that it costs about up to $3,900 per patient to implement this type of project. But also, there's little to no net change in primary healthcare costs when it's implemented correctly. And this is because patients' outcomes are better. And so they're doing better in terms of both their mental health care and their physical care. And so overall, that decreased costs. And importantly, providers, particularly your primary care providers, report increased satisfaction under this type of model. So we're not only supporting the patients in terms of their needs, but we're also helping with things like provider burnout to make them feel more supported. So I just want to give you one example of a system like this that was implemented by Blue Cross Blue Shield of Michigan. And what they had found was that their patients with behavioral health diagnoses made up 24% of their population, but disproportionately accounted for 49% of their spending. And that's across both mental health care and other medical problems. By 2021, they had 190 collaborative care practices enrolled in the program. Providers were incentivized. They received enhanced reimbursement for the time that they spent working within this model. And then they also got reports on patient metrics. So they were able to see the effect that this was having on their patients over time. So they would see, for example, how their patient population's PHQ-9 scores were improving over time. And the outcomes from this were pretty striking. So what they found with regard to depression was that the time to get to a PHQ-9 score of less than 5, which is considered remission, was on average 16 weeks, which is striking in comparison to the 52 weeks that they found it took for treatment as usual. Importantly, from the point of view of a payer, is they also found reductions in medical spending after they were projected by the end of the first 3 years that the spending was going to be 2 to 3 times, or the savings were going to be 2 to 3 times greater for patients enrolled in these programs. And what I thought was interesting is that they also found as a side benefit that this program increased access to psychiatry for the patients who didn't qualify for the program. So for example, patients with psychiatric disorders, and presumably this was because patients were being managed within their collaborative care practices. And so the fewer referrals to psychiatry were needed, which really freed up the psychiatrists then to deal with the patients who had the more serious mental health concerns that really required that level of specialization. And as a result of this, Blue plans across the country have rolled out collaborative care programs. But not everyone's ready to change their whole method of providing mental health care. So we want to bring in tools that really can be used today that don't require huge amounts of structural change and that support clinicians who aren't part of these types of models. And this is where we come to clinical decision support systems. So these are evidence-based digital tools that are used at the point of care. And the idea is to give clinicians the support when they're making diagnoses or coming up with treatment plans. They really should be based on the latest evidence and best practice recommendations from global experts. In order to be used, they have to be easy to access, and this would be things like via computer, mobile device, or within the electronic health record itself. It's important that these decision support systems have consistent sources of information for all members of the clinical team, including doctors, nurses, and pharmacists. The reason I point this out is I think as we see services and support for healthcare grow, we start to see mergers of companies or acquisitions. And so you might have a company that does traditional clinical decision support for clinicians. So you can imagine traditional topics where we give clinicians the information they need to care for patients. That may then merge with a company that has a drug platform that's really aimed at pharmacists. Well, you can see that if the information is not harmonized, that they may be getting different messages, and that can lead to confusion and at worst conflict over what the best approach is. It gets even worse when you bring patient education in, because if your patient education materials are not consistent with what the doctors are telling the patients, that's going to erode trust because now they're hearing and reading different things. So it's really important when you look at clinical decision support systems that all the information within those systems is harmonized across all of the products so that there's a consistent message going to everyone. These systems also support medical education and continuing professional development. In some cases, things like continuing medical education credits are available so you can help clinicians meet their educational goals. And these systems engage patients in their own care through the provision of patient education materials. So in terms of clinical decision support systems, there's several levels of support. Sort of the basic one that I think people are most familiar with probably is referential content. And everyone knows that clinicians need really robust, trusted content. Again, this should be coming from people who are really experts in their fields. But in addition to providing really robust content, it also needs to be content that they can use easily. It needs to be something that answers their questions directly and that's quick and easy to access. One of the things that we find is that graphics are often a form that clinicians gravitate to because they're much quicker to use at the point of care. So things like tables that provide information that they can access quickly, or probably our most popular type of clinical decision support in the referential area is algorithms. Clinicians really like algorithms that they can work through because it helps them quickly navigate down based on their patient to get their answer. And this sort of value of algorithms takes us to the next thing, which are advanced clinical decision support tools. The idea here is that instead of just providing referential content what the clinician needs to read through and sort of sort through some things that may be relevant for their patient, but there may be other things that aren't. And so it takes a little bit more time to get through. Can we give them tools that really help them just follow the path for their clinicians? So for example, here we have interactive algorithms. And what this does is it takes into account factors such as how severe is the patient's depression, or does the patient have disorders that would affect what medication you might pick? So if you're trying to decide on an initial antidepressant, maybe they have high blood pressure or they have anxiety, both of which would influence what you pick. And then also bringing in patient relevant factors, so side effects. One of the big problems in treating depression is patients get side effects from their medications, which leads to poor adherence, and so then they don't do as well. What these tools do is they allow the clinician to go through an interactive algorithm in this case apply the information that they know about their patient, and very quickly get to an answer without having to read about a lot of things that don't apply to their particular patient. These tools are even better if they're accessible through the electronic health record, and better yet, if they can help with things like documentation, because again, we're trying to make clinicians more efficient, and we're trying to take away some of the burden of the tasks that aren't particularly fulfilling to them. So then we take it even a step deeper, and this is where we get truly EHR integrated clinical decision support. So in this case, what we're talking about is clinical decision support that's being accessed through a specific patient's chart. So what we're doing is not only are we giving the clinician information that they can apply to their patients in general, but we're highlighting and really tailoring the recommendations to the patient that they are seeing right then and there. There are a couple different ways that you can provide this. You can make it as something like a passive alert, where the clinician, let's say a patient has depression and they're not on a medication. So there's a passive alert on the side of the screen. The clinician can click on that, and then they get taken into some clinical decision support to help them select an antidepressant. It's really important when you create this kind of clinical decision support that it be transparent. Clinicians don't like black boxes. No one wants something just popping up and saying, this is how you should treat this patient without it being clear why. So you want to make it really clear what factors went into that decision. What's the decision based on? Who is it that's making this recommendation? Is this coming from experts that you can trust? And you want access to the information and literature behind it. In this case, because it is a pull notification, the clinician is opting in. It's still a really positive system because it saves them time. So for example, we've given you a recommendation, but it can also go through and pull together in one place information from the patient's chart, so the clinician doesn't have to go searching for it. And if you do it correctly, you can have things like one-click ordering, so it saves some time in terms of placing an order. The problem, though, is that you are still dependent on the clinician seeking out this information and launching your app. Another way to do it is with a push notification. So this would sort of be your classic alert, where let's say you notice that a patient has depression, the PHQ-9 score is high, indicating that it's severe, but the patient isn't on any medications for it. Then you might want to push an alert to a clinician suggesting that they consider starting the patient on a medication. But it's a balance, because we all know that clinicians really suffer from a lot of alert fatigue. So if you're going to do this, I think it needs to be really carefully applied. You may need to make sure that you're giving the right recommendation to the right person at the right time. Just to take sort of an extreme example, the last thing you want is a pop-up recommending to an emergency room physician that they start a patient on an antidepressant when the patient is there being evaluated for an acute stroke. So it's all a matter of balance and really trying to tailor the type of support that you're providing to the needs of your clinicians. And then finally, we don't want to forget the patients. And part of these clinical decision support systems is patient education support. And again, it's really important that this be harmonized with the clinical decision support that our other clinicians, like physicians and pharmacists, are receiving. So in order to engage and empower patients to help improve outcomes, we need to make sure that we're providing patient education support that's really tailored to their needs. And it really needs to be empathetic. And when I say tailored to their needs, there's several different ways that I mean this. So one of the sort of most basic ways is the way information is being communicated in terms of things like language and health literacy. We obviously need to be providing patient education materials in a format that's accessible to our patients, which means it should be a language that they're able to read comfortably. And it also needs to be at a level of health literacy that's appropriate for them. So for someone with low health literacy, it's important that we use language that's very accessible. But on the other side, for someone who has very high health literacy, you don't want to give them something that's overly simplified. They may want really in-depth information. So you need to sort of judge what that patient needs and make sure that you're meeting them where they are. Also, how you deliver the information should be tailored to the patient. So what I've shown you here on the left is sort of a topic that you might give to a patient as a handout that they can read. But not everyone wants to ingest information that way. Some people work much better with video. And so having access to multimedia patient engagement is important because again, there you can give patients the information they need in a way that's most meaningful to them. And when you deliver the information needs to be tailored. So in some cases, it may be information that a clinician wants to deliver during a visit with a patient. So maybe going over a shared decision-making tool to help them weigh the different side effects of medications. Or maybe they prefer to get something in their patient portal so that they can look at it on their own when they have time, or maybe something that they can look at with their family members to bring other people in so that they have a little bit more support. And some people may prefer things like an app. So there's a lot of mental health care apps right now around things like symptom tracking or providing cognitive-based therapy. Or maybe some patients do better with phone calls. So an interactive voice response system where you call the patient, you have an automated call to the patient where you find out what their questions are and provide them the information specifically targeted to what it is they want to know about. And what we know is that if you have effective patient engagement, there are real tangible positive impacts from that. So patients will have improved outcomes because it improves treatment adherence, disease management, their overall sense of well-being. Importantly, patients have higher satisfaction and they'll trust their healthcare more. They often report a sense of ownership of their healthcare journey, and there are lower costs associated with patient engagement. So patients who are not engaged typically have 8 to 21% higher healthcare costs than patients who are actively engaged. And engagement is associated with patients taking control of their health, so seeking preventative treatment, actively managing their health, and recognizing difficulties early on so they can bring those to their clinicians before they become big problems. So talking about clinical decision support systems, you can see that there are a lot of pieces to this. And I think there's a real opportunity here for generative AI to sort of help expand our potential here. Some of the potential benefits include increased accessibility. So this can help expand access to mental health support for clinicians and patients. And that can be in a couple of different ways. So it can be expanding support for clinicians by creating more tools more quickly. And for patients, it can be doing things like taking that content and really tailoring it to that patient in terms of things like language and health literacy. Generative AI can also help with speed and efficiency. So it can help save time if a clinician, for example, is working with referential content, but can use AI to really hone in on the answer to the specific question they have, as opposed to having to read through a lot of content. Also can save time if it can assist with tasks such as documentation or filling out prior authorizations. There's a real opportunity for synthesis here. So when we're talking about EHR integrated clinical decision support, an important element of that is pulling information about the patient into the clinical decision support tool. Some of that information is in structured formats, like what medications the patient's on or what disorders they have, but a lot of it is unstructured. And so being able to pull all of those pieces together and put them in front of clinicians in a way that's really easy for them to access and saves them the time of having to root through the chart to find things, and potentially has the benefit of also highlighting some things that maybe they forgot when they were evaluating their patient that are important, can be really beneficial. And then, of course, we always want people practicing evidence-based medicine, and using generative AI on high quality data for training can lead to better evidence-based medicine practice. On the flip side, though, there's obviously risks of generative AI. So in the same way that using high quality data can lead to better evidence-based medicine practice, if you have poor quality data, that could do the opposite. I think we all are aware of high quality journals like the New England Journal of Medicine, where really strong studies are published, but there's also a lot of throwaway journals where things are published that aren't of particularly good methodologic quality. And we don't want that sort of information making it into our training sets because it could lead to recommendations that really aren't appropriate. And then we've also all heard of hallucinations with large language models, and we definitely would not want something hallucinated in terms of making a recommendation for patient care. Bias is another problem. So if the data sets that the generative AI is trained on isn't representative of the broader population, which we generally know is a problem, you're at risk of bias in your tools. And then we worry about loss of empathy. Generative AI can't provide empathetic one-on-one human interaction, and we don't want it to replace the clinician-patient relationship. So what are the safeguards that we can use so that we can bring generative AI in a way that's meaningful but also safer? So as I already alluded to, the clinician-patient relationship is really key here. Generative AI should be seen as a tool that supports that relationship, but not as one that ever replaces that relationship. We also need to make sure that AI-generated tools are really being carefully vetted. And when I say that, what I mean is we really need people who are experts in their domains, looking at what these tools are saying, what the recommendations are, and ensuring that they really are making good recommendations for patients and they're doing it in ways that are safe for patients. And then having done that, we need guidance. So we need a way to point clinicians and patients to reliable tools. Because as you can imagine, the longer this is out there, the more and more tools are going to come out. And the signal to noise ratio for quality content can be really hard to root through. So sort of summarize in terms of the different types of solutions we can think about, we really need to be providing support at all levels. So at a system level, we should be trying to add additional staff when we can, but when we're not able to do that, optimizing the use of existing resources within our clinics. We also should be looking at things like alternative care models to broaden the reach of our mental health care professionals when possible. For our clinicians, we need to be providing trusted, reliable clinical decision support through things like referential content, advanced clinical decision support tools, and ultimately EHR integrated tools supported by things like generative AI to really paint a full picture of the patient. And for the patients, we need to have effective patient engagement. We want education materials that are tailored to the patient, and we need vetted mental health support apps to do things like symptom tracking or help with therapy. And I'll just briefly say, in terms of when it comes to vetting mental health support apps, the American Psychiatric Association provides guidance for app evaluation, and they touch on things such as obviously the clinical content and quality of the content. Has it been validated? And also things like who is the source of the content and privacy policies, which is an important thing when you're dealing with mental health, that we're not pointing our patients at things that are going to put their PHI at risk because they don't have appropriate privacy protections in place. And so with that, I will hand it back to Julie.
Thanks, Anne. Thanks. To kind of wrap things up and maybe bring them back to the start where we talked about, the huge challenge, the potential additional cost to health systems, the risk of adding to burnout for clinicians. I think there is a compelling story around ROI. So as we invest and implement some of the measures that Anne was speaking about, there's a real opportunity to have a positive impact in health systems. But maybe what I'll do is just take that kind of one step further on the next slide. If we think about clinical decision support, and we're speaking about this in detail because this is the product category and the set of tooling that Anne and I live and breathe all day. When you think about what the impact is, we can never separate the tooling from the adoption, right? So what we see is you need to have the right tools. Ideally, they're integrated into workflow. There's a change management piece around driving adoption. There needs to be trust. In no way should a tool be used to kind of displace a clinician. It's really to empower them, to drive efficiency, to support them, to build their confidence, to facilitate those clinician-patient discussions. And then we need a series of mechanisms to ensure that there's ongoing high usage of these tools. And really, that trifecta is where you're going to really get the ROI. So maybe what I'll leave you with is, if you are thinking about looking at clinical decision support, specifically to support PCPs in managing this kind of overwhelming wave of patients with mental health conditions, there's a couple of tips that we would leave you with based on our work and what we see. Really involving the clinician in the decision. So kind of a top-down approach. Here's a new set of things, you have to use it. We found that doesn't really work. Think about the interface and how intuitive and user-friendly it is. Really what we see with our clinicians is the gap that they've experienced historically between their personal lives, where they're getting an Amazon-like experience, and then the tooling that they use in the professional environment, which isn't always user-friendly. That gap and that willingness to accept that dissonance is no longer there. So we have to make sure that it's a seamless, intuitive, enjoyable experience. The user interface is actually more critical than it's ever been. Linked to that is make sure it fits into existing workflows. Anytime one, and I'm sure this is not news to anyone on the line, anytime one is requiring very, very busy clinicians to go out and learn a different process, especially if it's not intuitive, we're not going to get that adoption that we need in order to be successful. Hopefully goes without saying, evidence-based clinical decision support, the latest guidance, the latest research, make sure it's written and structured in a way that gives clinician confidence in the decisions that they need to make is critical. On-site training can really, really help if this is really a big change for the organization, if this is not a common practice, just investing some time in training and working alongside them. I actually saw a comment pop up around incentivizing related to the collaborative care model. I'd say incentivizing usage on the CDS side can be very powerful and impactful. And then having an open dialogue with end users. So getting their feedback, talking to them really about how this is helping, not helping, how you can do differently, and setting up the expectation that this is going to be a dynamic, agile process, different tools, different content, different workflows, until we get to a place that both the health system and leadership and the end users feel really good that this is having the intended impact, reducing some of that burden on the PCPs and really building some confidence on their side around the decisions they're making, facilitating that clinician to patient exchange. So that's what we had planned for today. Gail, I can hand it back over to you.
Well, thank you so much, Julie and Anne. This has been chock-a-block full of really impressive content and really helpful for our audience. Thank you so much for sharing. I'd like to invite everyone to post their questions in the Q&A tab. We have about 12 minutes to engage in some questions. While we wait for some questions to come through, and there's already one or two in the chat, I would like to get us started and ask you if you could speak a little bit about some of the distinctions between the collaborative care model and clinical decision support. Obviously, a collaborative care model and clinical decision support tools can coexist in a very supportive way. But and we do have some comments from others that have implemented some collaborative care modeling in their primary care practices. But if you can't do that for different reasons, can you speak a little bit more about other options? Are there adjunct supportive models that could support, in addition, looking at clinical decision tools themselves?
Yeah, so the things like collaborative care models and clinical decision support definitely sort of go hand in hand with each other. I think clinical decision support systems, I think, are more universally sort of available. So they don't require that you change the model of how you're providing your care, because you're really just providing supportive tools. For things like collaborative care models, obviously that requires a fairly significant change in how you're doing things. And not everyone's ready to do that. So I did mention some groups do co-localization. And so everyone's still sort of doing their work in their normal way, but they're at least physically in the same space. And I think a lot of us learned when, if you went remote and had been working in an office setting, that you lose something when your colleagues aren't just right there. And if you can just pop your head in and ask them, hey, I have this patient, this is what I was thinking of doing. That sounds like a reasonable thing, right? And they can just say yes. That can save you so much time. And I think within internal medicine, we see this a lot because people, if you're a primary care physician, you probably know cardiologists that you can call up and ask a quick question. So you don't feel like you have to go and get a full consult. But you may not have those same relationships with psychiatrists or other mental health care providers. So if you're in the same physical space, that helps a lot because you know each other and it's a lot easier to ask somebody. But even if you don't have that, if you can even come up with a system where you have sort of a psychiatrist on call for curbsides and someone that you could just, again, call up so that you don't have to go through and do that referral, but you can just sort of talk it out a little bit, you really can provide a huge amount of support to your primary care physicians without making major changes to how you're doing your work overall.
Yeah, that's terrific advice. Take advantage of whatever resources you may have available within your environment. Are you seeing telehealth also playing a larger role in the collaborative care modeling?
Definitely telehealth, I think, is becoming a larger role in everything.
Yes.
So I think definitely, particularly when you start talking about the follow-up by your behavioral health care managers, that is not going to be in-person follow-up. So when you can do something by telehealth and see the patient, but also, clinicians seeing patients in follow-up by telehealth, because particularly for things like mental health concerns where it's really the discussion that matters, that also sort of opens up your ability to really connect with people a lot more frequently and a lot more personally, and sort of bring more of that empathy in.
Yeah,
Maybe to
that's great.
connect the dots, and maybe to connect the dots and some of the data we've seen, telehealth had a massive, massive spike during COVID. Any specialty, any population, anything you could do virtually was done. We've seen kind of a stabilization beyond the pandemic now. And one of the most enduring trends is ongoing high volumes of mental health patients using telehealth, using virtual care to get treatment. It's one of the largest and most enduring trends. So it's certainly a critical piece. Also increasing accessibility, right? If you're in a rural area, if you have mobility limitations, it opens up potentially treatment for you for the first time.
Yeah, thanks so much for sharing that. We have a somewhat related question from Anissa Brown from the Carillion Clinic, and she speaks to the fact that she has advanced clinical practitioners that have completed mental health certification, but is really struggling to find psychiatrists that are willing to review their charts and make recommendations or suggestions during their orientation period after completing their training at the university level. Have you seen other programs and any kind of remote options for where psychiatrists are supporting clinicians? Obviously, the training components here are another complexity. You did touch on those, but lots of nuance as well, I'm sure.
And I don't know if you have anything to add. I can just certainly say where we're seeing the most traction there, and there was actually another comment around this, is within kind of IDNs or health systems where you've got everything that's part of the system. We've seen a lot of efforts to engage the psychiatrists much more with the PCPs, right? So it can be around training, it can be around other things. I have yet to see great examples where you're not within the same organization. So I think that's certainly something to look at. And then linked to the other question, getting folks' incentives aligned is critical, right? If your psychiatrists, the psychiatrists are feeling the pressure too, right? And if their heads down and all they can do is treat patients, the capacity that they have to think about change management and supporting PCPs at a systemic level just isn't there. So we've got to free up their time, engage them in the right way, and then align the incentives if we want them to support, want them to support this. We've heard of working committees and other governing bodies where they try to free up some of their time to think, put yourself in the shoes of the PCP. What else could they do? How could they do things differently?
Yeah, very, very good points, Julie. I'm just wondering, and maybe this is more of a clinical question for Anne, but maybe you could speak a little bit about why is it that improving mental health care has a positive impact on medical outcomes? So the perhaps comorbidities that are so prevalent in that patient community.
Yeah, I think the key here is that you cannot separate mental health care from healthcare in general. And it's in some ways, it's sort of the most difficult thing in a way, because, if you have, diabetes, that may or may not have an effect on, you're dealing with your hip arthritis. But if you have mental health challenges, that can really affect every other aspect of your medical care. We know that people suffering from depression, for example, may not engage in their healthcare as much. And so you start to not care for these other things as much. And so it's really more about supporting the person overall. And that as you help their mental health care, you help them just become more active in their care in general. We see that they start engaging in preventative care more, so maybe you can prevent things. And I think that's why you see this disproportionate spending among patients who have mental health disorders. It's not that you're spending so much money on the mental health care that it's pushing everything way up. It's that you're really spending more on them across the board. They're much more likely to end up hospitalized. So it's really, by supporting their mental health, you're helping support them as a person, and that lets them take better care of their health in general.
And I can give one example. I remember a conversation we had with a PCP around this, and they were saying, for a lot of chronic conditions, so much of it is medication management, and so much of that is in the patient's hands, right? If you have high anxiety, if you are really depressed, your ability to manage your medication, to communicate if something is out of control, is just so reduced that the likelihood that you're going to need more intervention and more support is just greater and greater. It's those kinds of connections that I think are really, really important to keep in mind.
That's terrific advice, and frankly, you all summed it up when you talked about improved patient engagement, improves clinical outcomes, it improves the trust and level of satisfaction, and all of that decreases costs. I mean, we talk about the value-based care model so frequently, and yet you're seeing direct correlation in your results that you're achieving. So thanks again so much for sharing that. There is a comment from Dave Kunzman from UW Health that UW have happened to implement a collaborative care model as well early on in the pandemic, but would love to learn more about the clinical decision support tools. So thank you for providing information on how people can contact you and perhaps learn more and see live demonstrations of your tools. So
we will be at HIMSS. So I think I saw a comment about HIMSS. I'll be at HIMSS. Yes. I'm super passionate about the space. Anne and I are working on a number of areas here, speaking to health systems continually about how we can support them. Anybody wants to chat, brainstorm, share their thoughts, come and find me.
And thank you for your enthusiasm, as well as also your notes of caution relative to the AI applications, right? This AI is permeating all aspects of healthcare, and while we can all be excited about those opportunities, we also have to do that responsibly. So thank you for including that in your presentation today. I'd like to say thank you to both Julie and Anne for being with us today. This has really been an informative conversation, and our audience appreciates your support as well. Thank you all for joining us this afternoon. Please take a moment there's a brief survey. Please give us your feedback about today's webinar. Remember, the content, both the slides as well as the recording, will be available on the Scottsdale Institute website no later than tomorrow. So without further information this afternoon, again, thank you all and have a great rest of your day. Be well now. Thank you.